So good evening, everybody. Thank you very much for coming this evening. My name is Manoj Raval. I'm a colorectal surgeon here at St. Paul's. I work here with my colleagues, Dr. Carl Brown and Dr. Terry Pang, who's in the back. I see several familiar faces in the audience. Our fourth partner, Dr. Karmudin, is actually quite ill, and so unfortunately won't be able to join us tonight. So I'll be giving a talk this evening. I'm going to give just a brief overview of colorectal cancer care and treatment, and then we'll have a couple of other folks on the team to speak, and then we'll be ending up with Mr. Koonar over here, who's a patient of ours, who will be discussing his experiences through everything. So there'll be plenty of time for questions and answers afterward, and I do encourage you to ask questions. We're hoping to keep it more of a generic type of question and answer period rather than talking about specific patient questions, because without access to your charts and that sort of thing, it's hard to answer individual questions, but certainly we're here to help. So both in the forum here as well as outside will be available for questions and answers. Somebody was asking how long the evening will be. Probably about within an hour from now, all the talks will be done, and then it'll just be open after that. I would like to thank the St. Paul's Foundation for supporting us. They're responsible for the food outside, which is fantastic, and we have Suzanne Scott from the foundation here as well, so certainly pick her brain if you wish. So colorectal cancer is the cancer that nobody talks about. The symptoms are embarrassing, the tests to diagnose it are unpleasant, the treatment is quite invasive. It seems that everyone wants to show their big scar from their cardiac surgery, open heart operation. Nobody wants to see a belly scar from a colon cancer operation. So for several of these reasons, awareness of colorectal cancer is far behind things like heart disease and breast cancer. But things are changing, thanks in large part to the celebrity effect. This is Katie Couric, and it was Dr. Brown's idea to put her in this talk, which I think is great because her husband died of colorectal cancer at a very young age, and she underwent a live colonoscopy on TV about 10 years ago, and that sort of kick-started a lot of celebrities getting on board with spreading the word. So things are improving from that side. So today I'm just going to give a brief overview about some of the anatomy, a bit about cancer, what do we do about diagnosing it and treating it, what the recoveries from surgery is like, and what happens after you finish your recovery from surgery. And there are going to be many, many variations beyond what I'm going to be speaking about tonight, and so your case may be quite different than what I say here, but this is sort of a general overview. So what is the colon? Well, this diagram shows some of the organs in the body. So these are the lungs and the chest, and there's the liver and the gallbladder. Your esophagus, which is your feeding tube, goes down into the stomach and then empties into the small intestine. And this is the small intestine, and its job is to absorb nutrients from the food that you eat. So what it does once it absorbs all the nutrients is empty into the colon, which is starting on the right side here. And the colon's job is to basically absorb fluid from that waste matter or water. The colon and rectum together is called the large intestine. So it basically passes the waste matter onward and absorbs the water until it eventually becomes solid stool at the end, which is held by the rectum to be eliminated during a bowel movement. So the anus at the very bottom is a short, complex, but obviously very important muscle that holds the stool inside until the next bowel movement. So altogether, from the start of the colon here, all the way around here, can be somewhere between 4 and 6 feet, depending on what size of person you are. So the colon, like every other organ in the body, has blood vessels that are associated with to keep it healthy and so on. And these blood vessels are very important in colorectal cancer treatment, and some of the names of some of them are here. What's as equally as important as the blood vessels themselves are things called lymph nodes, and these are these little things that I've circled in white here that course along the course of the blood vessels, and they're very important in cancer treatment. You hear more and more about that as time goes on. The rectum is kind of a special area in the sense that it's in the pelvis. So this is a side view of the anatomy in a woman. So here you're looking at the tailbone. In front of it is the rectum down to the anus. Directly in front of that is the uterus and vagina, and in front of that is the bladder. So you can see here that these structures are really millimeters apart from each other. So if you had a cancer that was here, that was in the front in a woman, then that could potentially invade into the vagina, and we sometimes even have to take part of that. But even if it doesn't, we've got to be very careful and make sure we remove all of the rectum with the cancer in it while preserving all of these other structures. Similarly, in the male, tailbone's there, rectum and anus. Obviously no uterus, so we have a bladder. We do have a prostate though, so the cancer that's there sometimes goes right into the prostate in the rectum, and sometimes we have to remove that in a bigger operation to make sure we get the cancer out completely. So it's a very common cancer. It's one of the most common ones out there and will affect probably someone that you know. And the good thing is that it's almost entirely preventable with screening. If it does advance into a cancer, from a polyp to a cancer, it is very curable if we find it early enough. But the cure rate does drop off when it becomes more advanced. So the stage of the disease is actually essential to know. So here's just a diagram of a cutaway diagram of a colon, or some part of the colon, going from a polyp onto the different stages of cancer. So the cancer starts growing from this inner layer, and then it certainly grows into the colon this way. But what we're more interested in is how far out this way does it go. Because as it goes deeper and deeper through these layers, it becomes more and more advanced and develops the ability to spread more into these structures here called those lymph nodes. And those are important because if it gets into the lymph nodes, that is basically an open door potentially to the rest of the body and spreading to other organs and implanting. So that's really important. How important is it? Well, it's absolutely critical. So if we get into stage 1 and 2s, the cure rate is very high, but as we get into further and further stages, it can drop off significantly. So we would like to diagnose colorectal cancer in this realm here, but unfortunately, less than a half of the cancers that we diagnose as cancers are stage 1 and stage 2, and this can significantly improve with screening that we'll be talking about more and more. So how does it cause symptoms? Well, you can imagine it's basically, at its most basic level, the cancer is a growth inside a tube. So as it grows into the tube, it makes the colon narrow for the stool to go by. So you can have some bleeding, change in bowel habits, and you can get cramping as the stool is trying to be forced past the cancer here. And so these are some of the symptoms that might prompt a colonoscopy. But importantly, especially in the early stages, there may be no symptoms at all, and that's where colon screening is absolutely critical. This is the website. Sorry, it just spilled over here, but there is a provincial colon screening program. So if you just look under, actually if you just do a Google search for BC colon screening, you'll find it. So what about treatment? It's not just surgery. There are many different ways, or actually multiple methods of treatment that work in concert with each other. So it's not like you have this option or that option or that option. Basically everything works together, and so that's actually quite critical. Surgery is the mainstay of curing the cancer though, which involves removal of a segment of the colon or rectum with the cancer and the lymph nodes around it, which is in this fat tissue here. And then once the cancer's out, then if you have two healthy ends of bowel together, the idea is to reconnect them. Chemotherapy plays a role for more advanced or high-risk tumors and usually happens after surgery when it's indicated, and that'll depend on what the final result is. Radiation is for some more advanced rectal cancers, and it usually is done before surgery, and its job is to reduce the risk of the cancer coming back. Put another way, it makes the surgery more successful in achieving a long-term cure. So the goals of surgery can be to ideally cure the cancer by completely removing it. But in the situation where surgery can't do that because it's too advanced, in situations where there's bowel blockage and bleeding and perforation, surgery can also play a role to help alleviate symptoms, but understanding that we're not dealing with cancer cure in those hopefully small percentage of patients. So what is the surgery? Well, here's that picture of the colon again. So let's say you have a colon cancer that's right here. It's on the right side, so we do a right hemicolectomy. Makes sense? So the cancer is here, so patients often ask, well, why don't you just sort of take out the cancer that's here? Why are you taking so much? So you do the operation, then you reconnect here. Well, the reason we do that is because the cancer is here, but the cancer is in its most general form is bad because it spreads. So it can spread within the colon itself. but it can also spread to these lymph nodes, as I said before. And again, if it gets in there, then you have a risk of them spreading, the cancer cells to spread elsewhere. So that's why we make sure when we do the cancer operation, we have to take those lymph nodes as well, which is why we take that much. So going on down the line, as your cancer gets further and further downstream, same sort of thing, take a chunk of the colon on either side, reconnect. Same thing on the left side in the sigmoid colon. As you get down further and further, then you can see that there's lots of room on this side, but the room on the downstream side tends to run out. So in this case, where the cancer is in the upper part of the rectum, there's enough tissue on either side for us to take the whole cancer out and do a reconnection while still making sure that we get the cancer out. This connection here, when it's down in the pelvis though, we want it to ideally heal before any stool goes by it. So what we do at the same time as this kind of rectal cancer operation is to take this part of the bowel, which is the small intestine, and bring it out as what's called a diverting stoma or a loop ileostomy, which if you have it, the stool empties into a bag, and then it prevents any stool going by this way until that area has a chance to heal. So this is what it looks like on a patient. This is with the bag in place, and then hopefully at some point it gets reversed and you just end up with some scars. Now there are situations where the cancer is very low, where there's just no room at all on the downstream side to do a reconnection, and this is a situation where you really have no choice but to remove the entire colon and the rectum and the anus, and you end up with a permanent colostomy. So, word about stomas. So there are many different words for stomas. This can be a difficult adjustment. There can be issues with eating, managing stoma output. It can be a very psychologically difficult thing to get around, but thankfully we have some trained nurses here at St. Paul's and many other centers where a lot of these kind of operations are done to help manage. Thankfully, we have a couple of them here tonight. Beth and Heidi are up there. They have a table set out here, so those of you who might be interested in seeing what stoma appliances are all about, they have some resources there for you as well. No doubt there can be all kinds of problems with stomas, and thankfully we have people here to manage them. So stomas are one of those things where a lot of people think like it's the end of their life, but it's not really. I have a patient myself who had, for another operation, had the opportunity to not have a permanent stoma, but he did because he's a long-distance runner, and he felt that it would be much easier for him to manage his bowel movements than with a stoma bag than with risking the unpredictability of a bowel connection. So there are many people out there, celebrities, who you wouldn't even know necessarily that would have stoma. So how do I eat with a stoma? Well, we hope to get back to some sort of normalcy in terms of what you can eat with a stoma. There are a few restrictions for everyone to avoid stoma blockage. The eating patterns may be very different. One of my patients, Darren, and his wife, Leanne, actually were concerned with the lack of resources for how to eat with a stoma, that they actually got some chefs and photographers together and made a cookbook for patients with stomas. And this is available on Amazon, and they've kindly donated the proceeds to the St. Paul's Foundation. So you may have heard the term laparoscopic surgery, which is also known as keyhole surgery. And this uses multiple small incisions instead of one big one down the middle. And we use a camera that goes in one of them, instruments in the other incisions, and we operate on a video screen rather than directly in front of us. So instead of this incision here, you can have a few incisions that are a few centimeters long. The team operates like this, and we create a space inside the belly that we can fill it with CO2 so we can see what we're doing, and then we're looking on a video screen. This is what it looks like in the operating room, basically, with a few small incisions that you can see here, and us operating on the video screen. This is what it looks inside, using basically these instruments that substitute for our hands. And the hope is to get to a situation like this, where you have just a few small incisions. Now, why is this the way to go? Well, there's less pain, certainly shorter recovery and earlier discharge home if you can do it. It's cosmetically appealing, and that shouldn't be discounted, really. It's not better surgery because the operation that's going on the inside, the bowel resection and so on, is exactly the same as we would do with a big open incision. And it's not appropriate for everyone. There are some circumstances where it just wouldn't be appropriate for larger patients in some situations, larger tumors, if they've had a number of different operations before, and some rectal cancers it's not appropriate for either. So what do you expect when you go through this? You get this terrible diagnosis of rectal or colon cancer. Well, that's bumps you, even in our healthcare system, to the top of the priority list, basically. You get an urgent consultation with a surgeon, ideally within a couple of weeks of the diagnosis, of the referral. For most colon operations and some earlier rectal cancers, the surgery happens within a month or so, approximately, of seeing the surgeons. Some rectal cancers need radiation beforehand. There's no special change in lifestyle that you have to do between the time you get diagnosed and the surgery, really. You will get an appointment in what's called a pre-op assessment clinic, where you'll get prepared for surgery, and then you'll get some instructions for what to do leading up to those to the surgery. So you come to hospital the day of surgery. You have surgery under a general anesthetic, which can be a couple of hours or longer, 12, 15 hours sometimes. And we get you up moving and walking right on the first day as soon as you get up to the ward, because that speeds up your recovery. With all this, your usual hospital stay is typically around 3 to 5 days, but certainly can be longer depending on how your recovery is. It's really when you're eating solids and your bowels or your stoma is working and you've learned how to manage it, that you're off the pain medications through the IV, and that you're moving around well enough to look after yourself at home, hopefully with some assistance. There's a term called ERAS, or Enhanced Recovery After Surgery, which is basically a set of principles that we adhere to, and most hospitals that do a lot of colorectal surgery adhere to as well, to make sure you get the best recovery as quickly as possible. So no doubt, even if you have these little tiny incisions, this is a huge operation. So you're going to be monitored very closely during your hospital stay, perhaps even in a kind of bothersome way sometimes, but there'll be lots of nursing visits and checking your vital signs, and all other members of the healthcare team which will have a hand in your care to make sure you recover as quickly as possible. But even in the best situation, complications can happen. These can be something really minor, like a little wound separation of a centimeter, or it can be something life-threatening, because it's a major stress on the body and all of your organs are working overtime to get you over this. The bowel connections that we do, even if they look absolutely perfect at the time, can fail, and that can lead to severe infections and sepsis. So it's important to know the complications, but in over 10 years of practice, I don't think any patient has decided not to have surgery based on the complications, because the cancer is not going anywhere. If someone does have complications, they do certainly take much longer to recover from. So when you go home, you'll find that things like going to the bathroom, making a sandwich will make you exhausted to the point that you need a nap. Good days and bad days certainly can take a few months or even longer to get back to feeling like yourself again. We have very few restrictions. Really, it's just to avoid hernia that we ask you to lift no more than 10 pounds. And then bowel habits, particularly with rectal cancer, do change a lot over the following year or two. So that's important to know. After you go home, there'll be an early visit with your surgeon to review the pathology and see how your recovery is. The pathology is very important because we send whatever we take out to the pathologist, and they look at it under the microscope and decide, based on various factors, whether there's a role for chemotherapy afterward and what your follow-up should be as well. And then once you hopefully recover from all this, our job is to detect recurrence of cancer as early as possible so we can do something about it. And that's where, fortunately at our hospital, we have someone like Naji over here, who's a colorectal cancer nurse navigator, and she follows almost all of our colorectal cancer patients for up to 5 years and even longer to make sure that everybody gets the tests and scopes and clinic visits and blood tests and everything that you need to make sure that you have the best outcome. There is a document here, which I think we have some samples outside, called Colorectal Cancer Care Maps. We developed these in association with the Cancer Agency, and we work very closely with them to care for patients. And it gives you a very brief overview. It's due for updating, which we were just discussing, but it gives you a general overview of pretty much everything I've discussed tonight. And if you do a Google search for Colorectal Patient Care Maps BC, it'll be the first one that pops up, so it's available in PDF. So that's about all that I would like to say. I would like to thank the Foundation again for supporting this event. We're hoping that all of you get inspired to talk to your friends and coworkers and family about spreading the word for colorectal cancer screening. So next I'd like to bring up Naji to say a few words. I think many of you who are patients of ours might know her. For a few years now, we've had the good fortune of having someone who follows all of our cancer patients to make sure, as I said, that they get all the tests they need. There's very clear evidence that if you follow patients intensively and appropriately, then less people die from cancer. So that's her job, and if you don't already know her, then here she is.
Thank you, Dr. Referral. All right. Many of you have probably been contacted with a few people in the last couple of years. I guess we're in the 5th year of our colorectal surveillance, and it would have either been Nancy first, it could have been Judy or Sharon, so there's been a few changes in the interim, so now it's Naji. And you'll probably always say on the phone, I'm sorry, what was your name again? And I'll always say, N is for Nancy, H is for Heather, A is for Apple, J is Jack, and Igloo. So I guess just to give you a little bit of a background of where and how my career has taken me to this point in time, is I've been here at St. Paul's for 20 years, first as a ward nurse, then an endoscopy nurse, surgical daycare nurse, an educator, and a clinic nurse for the employees at Providence Healthcare. I've had the privilege of working with these 4 amazing surgeons through the years, and it's getting many of you ready probably for surgery. At some point in my career, I was in surgical daycare and possibly doing some of your abdominal pressures during the endoscopy suite when we finally diagnosed you. And now it's brought my attention to you as a nurse navigator. I'd like to call myself as your personal assistant in all things that require direction on your road to remission. So the nurse navigator position is pretty much what Dr. Referral was mentioning. It's a surveillance follow-up by the nurse navigator, usually happens for about 5 years or longer. My initial contact with you may happen anytime within the first 3 years, whether in the outpatient department, about 3 to 4 weeks post-op, or it could be on the ward when you do come in and one of the ERAS navigators will call me and say, Naji, there's a new colorectal patient. I'll come in and meet you, shake your hand, and give you a visual of who's going to be calling you every 3 months for the next 5 years. And that's usually dependent on your treatment plan and your surgeons and BC Cancer Agency, given whether you're having chemotherapy after your surgical intervention. I'm responsible for ensuring all your blood tests are done every 3 months for the first 4 years, and then you kind of graduate from the every 3 months and you go to every 6 months. Imaging is yearly. If you picked up one of these books that Dr. Referral was mentioning about, we will be working on doing a couple amendments, because on the page where it says follow-up, it used to be every 6 months, so I usually white it out when I send it to you in the mail. It's going to be yearly for the next 5 years. I try to accommodate the best way I can. I don't know if anybody here is from out of town, but if you're needing imaging, we try to make it as convenient for you as possible by making sure that you can have your imaging done closer to home as opposed to coming all the way back to Vancouver. If there's a will, there's a way. I'm going to find a lab or a radiology department to get it done for you so that it's not another stress or another added thing you have to do. I had one patient ask me last week when I met them in outpatient department, and he was kind of cold and standoffish. So, what's your experience with this colorectal surveillance anyways? And I knew I had to kind of win this patient over, because it wasn't one of those positions where he felt like he wants me to call him every 3 months to bug him, to do blood work, to do all these things. So I just pretty well just said to him, well, honestly, my father was diagnosed with rectal cancer with metastatic lung cancer in 2001, and he died at age 57 in 2004. I really wish I had this program, because it would have been really easy for me to just pick up a phone and say, what the heck do I do with this appliance? It just exploded on me. So I was, really thinking back as to how did I get to this position? If my father only knew what I was doing right now. He actually didn't want a nurse for a daughter. He wanted a lawyer. So the only time that he actually acknowledged the fact that I was doing something valuable was that when he was at his bedside, then he realized, I don't need a lawyer. I actually needed a nurse to help me figure out all this stuff around me. So at the end of the day, at the end of that conversation, I actually managed to get a smile out of him, and I think I won him over a little bit, saying that I could call him every 3 months. And whatever I can do, I am your resource nurse. I can talk to you about pretty much anything in terms of your experience during your diagnosis, your blood tests, and anything you might need. And if I don't have the answer, I'm very grateful that I can easily access these guys and the nurses and their MOAs within a few keystrokes, and I can try and find those answers for you. I'm grateful to know that I have the experience to empathize with the path that we all mutually have walked in. The tone has changed in my career because now I feel like there's another purpose, and I really hope I can fulfill that for you. And this will probably be one of the only opportunities I can meet you, unless I've met you in OPD already, outpatient department, or on the ward. So please come and say hello, introduce yourself. My memory's not that good. I have to take a lot of vitamins, but otherwise I hope I get a chance to meet all of you. And if you have any questions, I'll be available after this. But otherwise, if you haven't already picked one up, you can pick one of these up, but we will be working on changing on a few details of this. And if you don't know how to figure out your tracker, if you don't have one already, I have a few extra ones here, and then I can help walk you through as to what I'll be doing the next 5 years and how you actually read it if I haven't been clear or it hasn't been clear to you in the past. Thank you.
So as you can hopefully see, it kind of takes a village to treat a cancer. So, in our hospital, thankfully, we've got fantastic people that not just the surgeons. Whenever someone says thank you, I have to say it's a team effort actually, because it's not just us. It's the medical oncologists, the radiation oncologists, the anesthesiologists, the ward nurses, the stoma nurses, and the people that hold it all together, which is our office assistants. So 2 of them are here tonight, Anne and Lindsay. I'm sure many of you, things would fall apart without them. So we have to say thank you to everybody.